I plan to read my notes, but I think I'll just speak extemporaneously. Can all of you see my slides? Yes? Yes, okay, thank you. Just a while, let me just take this out, and I will have to sort of minimize myself. Okay. To the family of the late Lyndon Leesuy, to my esteemed colleagues, my friends, ladies and gentlemen, good evening. When Kenneth Hartigan Go requested me to deliver this lecture with this topic as its subject, I must admit I was a little, or rather quite reluctant and apprehensive. This is not an easy topic to discuss, especially in a pandemic such as we are in, but it is very difficult for me to say no to my classmate Ken. And besides, it is in honor of Asek Lyndon, who, while I did not know him for a long time, I distinctly remember as someone warm, sincere, hardworking, and dedicated to his duty, to his country. He was a joy to be with, and his passing was a great loss to all of us. And so, despite my reluctance, I accepted the invitation of Ken to deliver this lecture. It is to honor a fallen...
Existing isolation rooms for suspected cases in wards and emergency rooms. Recommendations for these findings include retrofitting and long-term infrastructure investments for infection and prevention control.
Anyone in the DOH now?
With regard to PPEs, the wearing of PPEs with incorrect sizes. Some
sorry, let's have some ground rules. Please turn off your video. Your microphone for the moment. As we sorry. All right. I think go ahead, Miguitas. Go ahead, sir.
May I continue? Okay. Please. It was actually Yusek Vergere. Okay. So because of all of this that Lyndon is, okay, it is to honor a fallen colleague, a member, a fellow worker in this vineyard called healthcare. And I'm certain he would have appreciated the importance of the topic, and this is why I accepted. At this point, I'd like to acknowledge the people I have collaborated with. This is just a small portion of the work we have done called Philippine Agenda, Health Agenda 2022 and beyond. Dr. S.P. Cabral, Dr. Ken Hartigan Go, and myself. So this is just a very, very small snippet of what we have been doing. I have no conflict of interest to declare in connection with this lecture. The COVID-19 pandemic wreaked havoc on the whole world, but it also brought to light many of the weaknesses of our healthcare delivery system. We never really had a strong healthcare delivery system, and we were hoping that our Universal Healthcare Act would fix a lot of the problems. Then the pandemic struck, and while we were able to trudge along, get by despite the bad systems, substandard public health delivery, poor compensation for healthcare workers, stagnation, and unmet needs prior to the pandemic, all of these came back to haunt us when the pandemic struck. But as in any crisis, this pandemic has also been an opportunity for learning, for growth, and positive change. And a lot depends on how we respond to the crisis. It is in this spirit that I deliver this talk. I commend the men and women of the Department of Health who have been working very hard throughout the pandemic. I have many friends among your career officers and staff, and I'm aware that you are stressed and overworked. After all, the DOH is supposed to be the lead organization tasked to respond to this pandemic. And there are many parts of the response that are effective, and we need to acknowledge this, especially in the absence of any playbook. Number one, the town hall meetings. This is one such thing that has helped a lot to get the various stakeholders in healthcare on the same page. These should continue as part of the new normal. And we have to maximize our virtual ability, internet, etc., to keep communicating with each other. The regular afternoon briefings of Yusek Vergere are also important. The establishment of and composition and performance of the vaccine expert panel and other panels as well. Although sometimes too many committees can confuse things, and a lot depends on the person who makes a decision on top. The One Hospital Command. Although it is impossible to keep track of the real-time availability of beds in a surge such as we are in now, The One Hospital Command, in essence, is a good concept. It is one of the innovations that should continue in a better normal. It can be a source of information as to where patients can go for procedures, which hospitals still have rooms, where difficult to find medicines are still available in hospital pharmacies. The permutations of the uses of the One Hospital Command are enormous. Then we have the strict prioritization of vaccines using the priority groups. This needed a lot of political will, and it was done. And I also am happy about the special privileges and limits put in place for fully vaccinated versus non-vaccinated. So these are good and should be commended. But there are also many things that we can do better, not only for this crisis, but for the future. And I speak tonight as a healthcare professional who has been in practice for 34 years, who has worked with the DOH as a consultant, advisor, who has collaborated on laws and projects. Especially as an iBank, as the founder of the iBank, I've been working with the DOH for more than 25 years. I'm also speaking as one who once served as an officer of PhilHealth. And I'm speaking as a thinking Filipino who wants to see better days for this benighted country and who has not given up on this dream. And I think most of us have not given up on this dream. So let me start. It all begins with the right leader. A DOH for a better normal will need the right leader. Before we can speak of any specific reforms, we need to address the matter of leadership. It starts with leadership. And while the change cannot happen without the right president, something we are working and praying for, the right Secretary of Health is essential. And if we hope to even come close to the DOH and the healthcare we Filipinos deserve. So what are the characteristics of a good Secretary of Health? First of all, commitment to national and public welfare above personal or political interest. Competence, understanding of the social determinants of health, understanding evolving science concepts, understanding systems and operations, management principles, understanding servant leadership, particularly in crisis situations. A good Secretary of Health, a leader, will have compassion and other characteristics that define a good human being, such as integrity, honesty, humility, accountability, and ethical behavior. I want to zero in on accountability, as it is necessary for a leader to be accountable in order for that person to be effective and to empower the people under him or her. A leader should be able to say, an accountable leader should be able to say, I'm responsible. The buck stops here. I will never make my people do what I myself am not willing to do. My committees can only recommend. I decide after studying all options, and I have your back. This is what an accountable leader, an empowering leader can say with conviction. A leader who habitually throws his or her subordinates under the bus is not an accountable leader, and it's not a leader we need for a new DOH. Accountability and integrity. It will prevent the wanton disregard for the protection of public funds and prevent the obscene profiteering by individuals or groups of individuals while we suffer through this pandemic or any other health crisis in the future. Accountability and compassion. This will enable us to have the right priorities, to value the life and service of our healthcare workers manifested by their timely and just compensation. So that it all starts with a leader. When we have all of that, we have to first have that. Only then can we hope to have the rest of the things I'm going to discuss tonight. Next is sensible health regulation system that is measured by results rather than just words or fund spends. No, you can have all the endless seminars, but if there are no results, then it's not a sensible health regulation system. And this sensible health regulation system will enable us to minimize red tape and increase transparency, increase efficiency and reduce wastage, encourage interagency cooperation and remove redundancy, remove confusing and inconsistent policies, and promote learning and overcome stagnation. So some details. Minimize red tape and increase transparency. I think this is a motherhood statement that is nobody can say is wrong. No? Do not make it difficult for people, for countries, for business entities to help us. Lessen consideration for business interests and put public welfare ahead of all considerations. Once this is done, then there's clarity of thought and decisions can be made quicker. What could have been if we had less red tape and increased transparency? We could have had donated modular ICU beds, earlier arrival of vaccines, more confidence and less suspicion about possible corruption and overpricing of vaccines and test kits. We could have had more timely decision-making that could have ensured more testing facilities at an earlier time. I don't think I have to remind everybody about the fiasco in the early days. Okay? Now, a sensible health regulation system will also enable us to increase efficiency and reduce wastage. An example of this is the supply chain management, which has not been addressed really properly up to today. No? There have been so many studies on supply chain management. Now, what is supply chain management? This refers to the process of choosing, bidding, procurement, transport, storage, distribution, prescription, utilization, and disposal of medicines. And there have been so many studies, commissioned studies, donated studies on how we can improve. But year in and year out, or every year, we are still confronted with the COA talking about expired medicines, talking about nabubulok na gamot in bodegas, while many barangays, barangay health centers, barangay units are still saying that we don't have enough medicines. So we have nabubulok, we have stored medicines, and we have a lack on the ground. We need to address the supply chain management. The DOH will have to learn how to buy in bulk, order in advance. We can actually modify or amend the procurement law. No, it should not be an excuse. I think any good president whose heart is with the people will see that to be able for the DOH to procure in advance based on previous experience, one must amend the procurement law. And I think the right president will do that and make it a priority. There must be the DOH must adopt a system, a software to be able to do an inventory of first in, first out. So simple. And we have all the technology to do it. We even have Unilab, we even have Zwellig. We have so many agencies that are willing and have the capacity to do this. We just have to work with them. Okay? This is just one aspect where we can increase efficiency and reduce wastage. Another one, okay, encourage interagency cooperation and remove redundancy. And we're talking about, this an example, is accreditation of hospitals. Is yearly accreditation of hospitals really necessary? This is a thorn we have to undergo every year. No? We have always to, even our PhilHealth benefits, our PhilHealth accreditation, our PhilHealth is delayed because of the delay and the necessity for yearly accreditation. Some of us are JCI accredited, Joint Commission International. They accredit only every 3 years. And this is the highest international accreditation for all hospitals. If they can do it, why can't we do it? Accreditation every 3 years, maybe with the stipulation that any sentinel event or red flag will warrant an investigation and possible suspension of accreditation. Have feedback mechanisms. PhilHealth can certainly work with the Department of Health. Are there fraudulent red flags? Is there fraud? Is there a high nosocomial infection rate? You can do spot checks without having to accredit every year. No? And there must be strict rules on what the DOH auditors can and cannot do to prevent harassment and extortion, because there are already complaints. Can the auditors tell you that because your room is not big, is too small, or your architecture is not this way, we cannot accredit you? There must be a limit to what they can do. Our country has already increased the validity of our passport from 5 years to 10 years, driver's license from 3 years to 5 years. Perhaps we can do the same for the DOH. These are things we can do because internationally they're doing it. And it's really not necessary to every year do the same thing again and again. Now, cooperation between the agencies or among the agencies within the DOH, something we should be doing more of, okay? And I'd like to share an experience of ours with Ken Hartigango during the time of Secretary Gadun, and I was the head executive staff of PhilHealth. When I entered PhilHealth, we had this perennial problem we saw of abuse in cataract surgery, illegal recruitment of patients, with the recruiters were already dictating to the doctors which intraocular lenses to use. And many of them were already smuggled, no regulation. Many didn't even have know where they came from. So there was no way our government, our FDA, or even our patients could run after the people who distributed the lenses if there was something that went wrong. So this is a lens inserted inside the eye. Imagine, and there was no regulation. Okay, there were some good ones who registered, but because of the rampant illegal recruitment and that they were being taken over already by syndicates, they were mostly smuggled. A lot of them were smuggled. So what did we do? We issued this circular on the guidelines on the diagnosis and management of uncomplicated cataract surgery. That's okay, but what was the most important part? And I want to read it. No? Only Philippine FDA registered intraocular lenses, devices, etc. could be used. Fine, you can always say that, doesn't make them follow, but this is what made them follow. All intraocular lenses that are worth their while, which are legitimate, have stickers that come with them. The stickers contain the grade of the power of the lens, the brand, the serial number, okay? And we have a ID where we put that so the patient knows this is my lens inside my eye. We require that this same sticker be placed in the operative technique and the CF2. The CF2 is what you use to collect from PhilHealth. Unless we see that, PhilHealth will not pay you. So that caused a big stir. And I remember the day the circular came out, people were calling us frantic. Paano yan? Walang sticker yung aming IOL. Sabi namin, lagyan nyo ng ano, gupitin nyo yung box, lagyan nyo yung, kasi even the box has all this information. Stick the box, a label in the CF2. Photocopy. Wala kasi siya, ano bang brand ng IOL ninyo? Wala rin siyang brand. In other words, these were the smuggled lenses coming in plastic bags from God knows where. So, with one move, we achieved a lot of good. We ensured greater safety of patients. We removed the power of syndicates over the doctors because no decent manufacturer of the IOLs will deal with the syndicates. We lessened the fraud. We awarded legitimate IOL distributors. We improved FDA regulation. We assured accountability. It entailed really close coordination. Every time there was a distributor that got accredited, got their certificate, we were informed in PhilHealth and we informed the ophthalmology community. Simple lang eh. And then, but we had to keep evolving our IT system because, they always find ways. For example, some were using the same stickers for more than one patient. So we had a way of checking if the serial numbers was used again. Then it was not again reimbursed. So these things can happen. No? And the problem is sometimes in government, you're in the same office, you're in the same floor. It's so hard to get people to talk. So difficult. We should change that. Another thing we can do is remove confusing and inconsistent policies that make life more difficult and result in more wasted funds. And this is happening now under the COVID response. And I'd like to quote and present this article, this piece written by Attorney Joel Butuyan. He's a columnist for the Inquirer, but he also happens to be the husband of the mayor of Mayor Tin of Alcala and Isabela, and both of them got COVID. And I'd like to just read this part. When someone shows symptoms of the virus, she is first subjected to an antigen test by the local government at the cost of 800 pesos. Then the national government, through the Department of Health, then makes a confirmatory RT-PCR at the cost of 3,800. That's a total cost of 4,600 per person just to confirm what she is already experiencing. Not much is spent with no treatment or vaccine yet that will address the illness. Positive result in a symptomatic person. All the rules of the WHO and the DOH and their circulars, as I will show you later, say that a positive antigen test in a symptomatic person and in their close contacts is already confirmatory. You do not need to reconfirm with an RT-PCR. So why is still this much? Why is an additional amount being spent? This is the latest update from Dr. Marisa Alejandria. Again, you confirm case definition. This is again the circular from memo from DOH. So DOH and WHO are in one in the logical interpretation of a positive antigen test in symptomatics and close contacts. Very important, especially in a surge. Okay, they are final. No need for confirmatory PCR. If it's a negative test in a symptomatic, then you need a confirmatory, but not when it's already a positive. So in other words, they all agree to the old saying that if it looks like a duck, walks like a duck, and quacks like a duck, it is a duck. Okay? So bakit pa pinagagastos ng extra na sila mismo nagsasabi, hindi naman kailangan. Pero dun sa probinsya, sinasabi rin nila na kailangan. So anong dahilan? The discrepancies and wasted funds don't stop with the diagnosis. It is also rampant in discharging patients and allowing them to reintegrate into the community. Why are RT-PCR still required of recovered patients when it has been deemed unnecessary, except for here, immunocompromised adults? No? For a long time now, since November, there was already a DOH memo, okay? And it's again a rule, even of the WHO. So I can quote, I can show you all these memos. So this is again from the article of Attorney Butuan. It increases, no? Okay, compare the 4,600 testing expense with 1,300 cost of 2-dose vaccine per the government's own estimates. The amount we spend to test one person is equivalent to a cost of vaccinating 3.5 individuals. It increases to 6.5 individuals who should benefit from vaccination instead, because government spends another 3/8 for another RT-PCR before a person is certified virus-free. Again, the DOH in the provinces goes against the DOH circulars and memos of Central. So that's a whopping cost of 8,400 to test a single person instead of being used to vaccinate 6.5 individuals. 800 becomes 8.5 because of tests that the DOH and WHO policies say are no longer necessary to properly diagnose and determine recovery of a COVID-19 patient. A whopping difference of 7,700 per person, enough to vaccinate 6.5 persons or spend for more oxygen tanks, medicines, high-flow O2 cannulas, etc., etc., etc. You know, I see that Raymond Law is here. You know, their group, our group even, the Project Art Group, Jeanette Garin, they were pushing for pool testing. All kinds of testing have their role, okay? Individual PCR testing has its role. Pool testing has a role when you have a low reproductive rate and you want to test as many people as possible. Antigens have a role when you have a surge, you have a high reproductive number in the community and you want results right away. You have a lot of symptomatics. Why waste money? No? Hirap na nga ang tao, pinahihirapan pa. Then even the lowly antibody test of high sensitivity and specificity can help in seroprevalence studies, okay? So as long as they know how to use the test strategically, we can do so much more. A sensible health regulation system would promote learning and overcome stagnation. It make it mandatory for the health regulators to perhaps spend time in the hospitals like flies on the wall to see how the regulations are affecting the running of the hospitals. Are they helping? Are they practical? Are they not helping? And maybe we can think outside the box to overcome obstacles. Now, herd immunity. It is defined as, it is known also as population immunity. It's the indirect protection from an infectious disease that happens when a population is immune either through vaccination or immune developed through previous infection. Of course, we all support achieving herd immunity through vaccination, not by purposely allowing a disease to spread through any segment of the population, as this would result in unnecessary cases and deaths, and it would make our health system collapse. That's very true, okay? But in many developing countries like the Philippines, where vaccines are not readily available, there's a surges, like now due to Delta, no? Where they come in clusters. We know there is underreporting of cases, and definitely underreporting. There's continuous devastation of our economy because able-bodied Filipinos who are not immunocompromised are confined to quarantine even after recovering fully from COVID-19. What else can we do? Aside from twiddling our fingers and desperately waiting for more vaccines and just quarantining and quarantining no end. What else can we do? Various studies, both peer-reviewed and preprint, have shown that those who have recovered, okay, or what you call seropositive individuals who have recovered from COVID, one vaccine is all they need to achieve high levels of protection against reinfection, hospitalization, and death, proven over by several studies, and I have them here. These are just 3 of them. No? The recovered also achieve the same or even higher levels of antibodies after just 1 dose as the infection-naive individuals after 2 doses. So you start at a certain level, the recovered has already a baseline of high antibodies, the naive does not. You give them 1 vaccine and they have, the recovered has a much, much higher antibody production than the one who never got infected. When you give them a 2nd dose, the one that never got infected only reaches the same level as the one who got infected after the 1st dose. And there's no difference. In other words, you only need 1 dose to achieve the same level as 2 doses in those who have been infected. This is a major possible strategy that we can use. No? In fact, Israel has decided to just vaccinate those recovered from infection once. And you can actually vaccinate much more. But first, you have to know who got infected. Another thing is, when you have less vaccines, the ratio of vaccine to the population is lower, then it becomes even more important to consider serological status with the other prioritizations such as age, risk, etc., in determining who gets infected, who gets vaccinated. That way, you can also spread your vaccines further. Those who already got infected, just give them one. Then you can actually use the ones, give the 2 doses to those who really need them, the vulnerable and those who never had infections. 2 studies in preprint from Israel have shown that natural immunity from COVID-19 infection appears to render stronger and lasting protection against reinfection, hospitalization, and death than vaccines. So again, I know this is controversial now, but it is coming out, and it sort of validates the earlier studies from the National Institutes of Health in the US prior to the vaccines, showing that indeed infection renders long-lasting immunity. Goldberg from Israel went as far as to even question the need for vaccinating those recovered in light of the severe global shortage of vaccines. So we have the concepts of equity and justice. Couldn't the DOH push for using seroprevalence to be able to spread our scarce vaccines more so that we know who needs only one, we know who can be delayed because they still have antibodies? Then you can give it to the ones who really need it without waiting for the surges to happen. Just food for thought. Thinking outside the box. And anything that will help hasten our recovery will really be very welcome. I'm just going to show you 2 slides from the presentation of Secretary Carl Chua, Socioeconomic Planning Secretary, to show you the total cost of COVID-19 and quarantines on the present and future generations. And this is jolting. The long-run cost of COVID-19 and quarantines to present and future society is estimated to be 41.4 trillion. 4 trillion from last year, and in the long run, about 37 trillion. Because of consumption, investments will be lower in the next 10 years. These are predictions. Due to low demand in sectors that require social distancing, consequently, tax revenues will be lower. After the 10th year, the economy is expected to converge to pre-pandemic growth. 10 years. Then workers' productivity will be lower due to death, illness, and lack of schooling. The impact on productivity is likely to be permanent for those over 40 of working age. Very grim, right? This is the consequences naman of face-to-face school closure. Long-term COVID impacts include less learning. The Philippine score was already low to start with, okay, low. And according to World Bank, our 12-year learning is only equivalent to 8 years of learning, because based on the results, the international results assessment, this is likely to fall as a result of the long school closure. According to the ADB, each year of lost schooling translates to around 10% permanent lower wages in the future for our students, our children. All these mean that pandemic and school closure are exacerbating the already unequal access and lower quality of education in the Philippines. Grim. The scenario for just continuing with the same lockdowns while waiting for vaccines that may not come for a long time is grim. Can the DOH call for funding for community studies on seroprevalence? I know some vaccine experts are asking for this. We also had a proposal with Dr. Manalat David some time ago, but we could not get support. We are likely to have more immunity than we have bothered to find out. Why? Simply because we are grossly underreporting cases. So many families are ashamed or afraid to tell people they have COVID. They stay at home. They heal at home. A vast majority of them are mild, so they can heal at home. The Delta variant has created clusters of unreported infections. Perhaps if we do this, if we look for seroprevalence and use it as a weapon, some part of our armamentarium to help us, we can shift paradigm. The recovered are survivors who can help the country. No stigma. It will help us arrive closer to the real number of infections also. Because if you tell them that, oh, kung nag-recover ka na, isang bakuna lang ang kailangan mo, basta magpresenta ka at sabihin mo sa amin ang talagang nangyari, we may arrive at the real number of real infections. Yeah, that's also good, that's also bad. For me, it's good. Knowing the seroprevalence could make a big difference rather in helping our country emerge from the abyss of COVID-19 faster. Now, After we do the health regulation, the sensible health regulations, DOH must closely coordinate with other line agencies as a matter of policy, not only per project, but as a matter of policy. DOH and DALG should really, really closely coordinate. Now we have a devolved system. So they must establish deliverables of LGUs for which they will be accountable, specific deliverables that DALG and DOH will say, okay, you are evolved, you're autonomous, but this is the minimum that you have to deliver. Identify those LGUs that are capable of delivering efficient, decent healthcare and give them more autonomy and make them examples for other LGUs. Identify the LGUs that need more help and closer supervision and give them this, more help, closer supervision, and even financial help. Establish a monitoring system, maybe a community satisfaction tool. When I was in PhilHealth, I said maybe we can have a Hall of Fame, Hall of Shame, I don't know, maybe just a Hall of Fame. So people will see, hey, kaya pala nitong LGU, bakit tayo hindi? Anong ginawa nilang tama? Recognize those LGUs delivering exemplary service. Let people know who they are and what they are doing. DOH must also closely coordinate with other agencies such as Department of Education. We must strategize to make face-to-face learning happen soonest. You know, if we don't have any concrete plans, by the end of September, only the Philippines and Venezuela would be the only two countries in the world that would not have any plans to have face-to-face, who have not reopened anything at all, just the two of us in the world. DOH and DepEd must strengthen school feeding programs for malnutrition. It's already there, but we can further strengthen it. We must also use the schools to monitor any children who may be in danger because of abusive and dangerous homes. And the rate of abuse is rising because of the pandemic and the lockdowns and the frustration and the joblessness. The DOH and the DepEd must incorporate health literacy in the curriculum. And this must include skills for being able to discern truth from fake news. This is a very important skill, and we must start at a very young age. Then the third agency that I can mention tonight, the DOH and the DICT, it's a relationship yet to be maximized. No? Consultation, teleconsultation for patients in areas that lack the necessary specialists. We learned so much about teleconsultation. It has enabled us physicians to see patients who cannot come to us. And it has even enabled us to continue teaching our students, okay? Continue teaching our students who show us patients, no? Whether it's in private hospitals or in government hospitals like PGH. Surely we can do the same for other hospitals around the country. So the teleconsultation is a very important tool that we learned because of the pandemic. It will also enable us to hire nurse clinicians. Some might not agree with me, but the problem in many barangays is that they don't have doctors. You send them there, oh, bakit wala kayong gamot, wala nangyari? Wala kasing doktor eh. Kailan babalik, hindi namin alam. No? Perhaps we can train nurse clinicians to do the simple tasks of a barangay health worker because they can. No? We can give them capitation that the doctors there would get, plus the salary. This will help keep the nurses in the country. And this is a special training. And with the teleconsultations, they can always call a friend. They can always do an SOS with a physician on standby if they have a problem. But most of the things they can do on their own, okay, with the necessary training. And we can eventually develop an integrated health information system that patients can easily access their health information no matter where they are. This would make PhilHealth truly portable. The One Hospital Command can further evolve to become the backbone of this integrated system together with PhilHealth. So it can continue, even beyond this COVID-19 crisis, it can continue to grow beyond what it already is. Okay. So I'll stop there first. Ken told me, Gita, don't say too much. Think of this as a striptease. That's what he said. Dahan-dahan lang. Because our health agenda 2022 and beyond, it's a very vast health agenda. So this is just a small portion of it. So this discussion is by no means exhaustive because health care involves not just the Department of Health, not just PhilHealth, not just FDA, but so many aspects of government. Okay, so it's not exhaustive. PhilHealth alone, I'll need another lecture, maybe a whole day to discuss what needs to be done. Okay, that's an all. But all the suggestions I presented are doable. They're doable. However, all depends on the right leaders, starting from the president to the Secretary of Health and to the other cabinet members, who then will also be responsible for their respective agencies. This is my dream, to have a president who will say this: mga ganid at walang hiya, huwag ninyong pakikialaman ang kalusugan. Give our country a chance to heal. Lay off or else. Signed, President Blank. Sana ganyan ang ating magiging presidente. I started discussion with leadership and I will end with leadership, because unless we have the right leaders, the servant leaders who can do all of this, then nothing will really come true of the things we talked about, of our dreams and aspirations. Just as a fish starts to rot from his head, so should reform start from the top. Only leadership by example, from servant leaders who are accountable, brave, compassionate, honest, competent, can make all of these aspirations come true. And so I will end this Lyndon Leesuy lecture, memorial lecture, with 3 prayers. One is that may we vote wisely in the coming May 2022 elections, using our conscience and power of discernment as our guides. That those of us who are more learned and still with hope in our hearts will try to educate those who are confused and encourage those who have grown cynical or indifferent to give elections another chance. And that God, in His infinite mercy, will reward our tenacity and our refusal to give in to despair with good leaders who will inspire all of us to work together towards a better tomorrow. Those are my 3 prayers for us, for all of us. Stay safe. May God bless all of us. And thank you.
Thank you very much indeed, Dr. Mingita Padilla, for gracing this occasion and giving us a rather interesting talk about how the reforms that you're looking forward. And I agree with you that they're very doable only if we put our minds and hearts to it, no? By choosing the right leader. I mean, we have another 10 minutes before we come to a close at 7 o'clock. And well, first let's give Dr. Mingita Padilla a round of applause or virtual applause for this lecture. I see Representative Janet Garin. Dr. Garin is still here.
Hi, Janet.
Yeah, Janet, would you like to give a reaction or contribute to some of the discussion? Maybe say a little thing about Dr. Lyndon as well. Oh, I also see Jonas in the audience. Yeah, thanks.
Jonas Rosario is here.
For joining
a
us.
lot of people are here. Yeah.
Yeah, Jonas of Philippine General Hospital. Janet, would you like to open the salvo by asking questions or contributing to the talk?
Can I say something about Janet Garin? Yeah, because, when I became head executive staff of PhilHealth, she asked me, because it was a tumultuous time for her as well. She took over Secretary of Health under tumultuous times. And, I believe she had political will. That's why she also made enemies. No? When you have political will to make reforms, you make enemies. But that small vignette I shared about the IOLs and PhilHealth, I was her eyes and ears in PhilHealth, but without her support, we couldn't have done that as well. And that thing we started in 2015 is still being done today because it works. It works. No? So she also empowered us to think out of the box. Hi, Cheche, I see you. She says, great, apologies. She's doing something.
Yeah, hi, Mingita, hi, Ken.
Hi, Jeanette.
Yeah. Basically what this lecture is not just about COVID and
no.
the new normal and everything. It's actually an eye-opener on how systems and management impacts on public health. And the people are wanting of information. And it's very important to have speakers who are not only respected, but who knows the subject matter they are discussing with. And as we observe in other countries, information about COVID and the pandemic is being given by experts. And that is why there is no confusion. So in addition to what Dr. Mingita Padilla, who is not only bent on pushing for outputs, but more so on creating a difference, it is really very important to be part of public health. Because if you are not part, if you are not aware, if you do not play your role, then the future generations, including the current generations, will have to suffer. So thank you very much, Mingita, Ken, and we do really hope that Lyndon was here with us. I remember him in SARS, I remember him in MERS-CoV, I remember him in Ebola. Whenever it's toxic, he will just eat, but always work. So thank you, stay safe, and we do look forward to other similar lectures.
Thank you, Jeanette. I want to say something about Lyndon and eating. One of the few times I really spent a lot of time with Lyndon is in Bangkok during the first dengue, convention. There was one dengue meeting, and I was sent there by PhilHealth, and it was over breakfast, always a hearty breakfast, that we will have our best discussions with Lyndon. And we talked about how PhilHealth can make better packages for dengue, particularly dengue. No? So they were very, very, very productive and very, very nice. Napakagaan niyang kasama. And we did so many things, and we were able to achieve so many things, but over food. So masarap siyang kasamang kumain, si Lyndon.
Mingita, that meeting that you had with Lyndon in Bangkok, that was not, it was a dengue meeting, but it was organized, I recall, by the WHO, World Health Organization, to bring different regulatory authorities of 7 or 8 countries together.
Yes, that's correct.
So I remember that.
It was the first, yeah.
Well, actually, the first was in Brazil. The second.
Oh, okay. I'm sorry. The second was the second.
That's the second, and then the third one was in Geneva. I remember that because a paper came out of that to describe the regulatory process.
Yes,
there was no shortcut, no, in the regulation of.
No, there was none. There was none. That's why we know there was no shortcut in the regulation of the dengue vaccine. Definitely.
Yeah, I had to put something in the chat box. When you showed the slide showing PAO, I had to make it's a Philippine
Academy of Ophthalmology. Yes, I'm sorry. It's like the same shortcut. PAO is a good PAO. It's a Philippine Academy of Ophthalmology.
Yeah, not the other agency that we're.
No, not the one that's giving you a lot of grief. No, not that. It's the ophthalmologists.
Well, I guess anybody can pose a question, and I will give you the floor if you want to ask a question. If you're shy, just put it in the chat box, and I'll be the one to read it. If you have. There's a question. Where would you place FDA in the context of the new DOH? Maybe a short answer. I think you said something about.
Yes, but maybe Ken, would you like to say something? Because I know you have a lot of ideas. Well, basically the same rules that I talked about for all the other agencies should apply. Lessen red tape, okay? Make life easier. I remember when you were there, I think there was a system that you established that made things easier. Isn't it so?
We have a document tracking system so that the papers don't get lost.
Yes.
And it's to create fairness and opportunity for industry, to the point that the head of the industry who has a product registered, he can actually trace where the bottleneck is in terms of the movement of the documents for regulations and license.
I remember that very well. And I mentioned the FDA there as interagency cooperation among the DOH and the FDA is an attached agency. So was PhilHealth. My example with the IOLs was just an example of how the 3 agencies can really work together. And when they put their heads together, especially with the IT is essential. No? Then life is so much easier. Life becomes so much easier. And I get the same thing for the FDA. I think I'm trying to say is that if we have the right systems and the right attitude, we can make life easier for everybody. Huwag na natin pahirapan ang mga nahihirapan na. No?
Yeah.
Huwag na natin pahirapan. No? I remember FDA used to always communicate with PhilHealth if there's a new device that got registered, because PhilHealth can now make sure that only those who use FDA registered devices will get compensated. And it doesn't have to end with IOLs. It can be anything. It can be prosthetics. It can be, anything at all. So that's how the FDA can, and if there's really a need for something, compassionate use should come fast. Again, speed, efficiency, transparency, and lessen the red tape, for heaven's sakes. It's not.
Yeah, but there's another thing that perhaps you omitted to mention is patient empowerment.
Oh,
The
yes.
patient now know what he's getting or wants getting from the doctor, and it's not going to be a house product.
Yes,
And
I think I said that because it has to be given accreditation and registration. No? And again, it's really sad, but it's true. PhilHealth holds the stick, the carrot and the stick. It's the money, and they can also remove your accreditation. Then if you work with the FDA, you say, okay, if you use a house or a product which is not registered, not legitimate, then we won't compensate you. So it empowers the FDA as well. And the patients also are safeguarded. I think why do you think, John? What's the question? Why do you think DOH cannot? Is there a question from Jonas? Okay, Del Rosario.
Yeah, okay, I'll read it. Why do you think DOH cannot implement a certain policy nationwide? Is it because there's a disconnect with the LGU, who has been rightfully empowered? How do you balance this?
Okay. Yes. Actually, I said there, the DOH, it is devolved. The DOH must have an ongoing relationship with the DILG. It shouldn't just be, disconnected, because then the DILG can now sell it down into the LGUs. Ito ang regulations. But you see, it's not the LGU that's making them pay for more tests. It is the DOH themselves in the local governments who are making these tests, unnecessary tests required. I asked Joel, ano nangyari sa inyo? Kayo ba nagbayad? Hindi, ang LGU nagbayad nila kasi the LGU pays for the antigen test. It was the DOH themselves who paid for the required test that they required. So it's not the LGU, it's the DOH themselves. It's the regional offices. It's the representatives of the DOH themselves who are not following their very own policies. And this is what we cannot understand. There has to be a way. But Jonas, we said it in our discussion. There must be a continuous discussion, relationship, and there must be written accountabilities. Written. This is what we expect. You're under the DILG, but DILG will say, ikaw, itong minimum na kailangan niyo gawin. So that's how you can actually make sure that even if it's devolved, they'll still follow the minimum. But it has to be like that. Now, it also depends on the DILG secretary, the DOH secretary, if they get along and if they want to do that.
That's politics. Nikita, mindful at the time, please allow us to entertain two questions from the audience.
Okay.
Let's first call on Marita. Briefly introduce yourself, and then followed by Dr. Raylo.
Okay.
Marita, you have the floor. Unmute, please.
Thank you very much. I was just invited by, I am a family friend of the Leesuys, and
Okay.
I am in Melbourne at the moment, and my God, it is giving me goosebumps hearing you, Dr. Mengira. Oh my God, it's really like I say it because I'm so desperate. What's been happening in our country. I'm just one of a typical, citizen, and hearing that there's a hope. I said I feel like challenging you. The reason why I'm here now, the reason why I'm saying this is challenge you. Please make your suggestion be loud enough for it to be heard. So please don't wait for me. It seemed to be I was trying to really sort of hear all those suggestions, and I know it will make a massive difference in what's been happening to our country. And please, I don't know. Of course, this is just a typical citizen's comment. Please, why can't you challenge yourself to have that and be heard and make it happen?
Actually,
Not wait for me.
Yes, actually, Marita, we're going to do that because
Yes, thank you.
because no, ganito. This is just the start. We have the nice thing about technology is we have a recording and we can share it with all of those who gusto niya mag-president.
Yes.
O, tingnan niyo to. Pwede naman yung pag-isipan nito, no? And then our health agenda, we can offer it to all those aspiring. And then you can think about it. It's possible, di ba? But it all starts now with the leader. No? Kasi masyado na tayong nagdurusa. We're suffering too much.
Yes,
We
yes,
don't have-
indeed.
I'm so appreciative of the fact that you're in Melbourne. You're in Melbourne.
Yes, I am.
Your heart is still here. Your heart
It is, you know, my heart and soul, my whole being is in there. And
that's how it is,
I really follow it up.
That's how it is with so many Filipinos all over the world. Their heart is with us and they want to see hope. And we're trying to do that.
Yes.
We will share this.
Thank
We will share it
you.
with whoever wants to listen. Okay?
Yeah.
Yes. Oh my God, it's so brilliant. Thank you very much. Thank you very much.
Thank you, Marita.